Hello, my name is Andrew Poore. I practice anesthesia at the University of Kentucky. This presentation is a review of Neuroanesthesia keywords for the ITE. Throughout the presentation, I'll have keywords listed like they are on the slide. I've tried to cover the majority of topics and keywords, but I have missed some. The ones that I've obviously missed, I've put a little star next to so that you can review those. Bolded keywords are ones that were asked on this year's ITE. Of course, if you found this presentation helpful and would like a copy of the slides, just please send me an email. And if you spot anything that might need a correction, again, just email me. I'd like to continue to update and enhance this lecture. Let's jump in. The first topic is the blood-brain barrier, which is unique in that it severely limits which substances can pass through the vascular endothelium. So small, uncharged, lipid-soluble, non-protein bound substances can pass through, whereas large ionized molecules are limited. Now, the blood-brain barrier can be disrupted by severe hypertension, tumors, trauma, strokes, infection, hypoxia, and seizures, to name a few. The cerebral metabolic rate of oxygen is used to express cerebral metabolic rate. So essentially how much oxygen the brain is utilizing. It averages out to be about 3 to 3.8 mLs per 100 grams per ml in adults, which is about 20% of total body oxygen consumption. The brain utilizes glucose as its primary energy source, but it can utilize ketone bodies during starvation, such as acetoacetate and beta-hydroxybutyrate. Now, the brain receives about 20 to 25% of resting cardiac output. So that's your cerebral blood flow, which can vary with metabolic activity. You can also get increased regional blood flow depending on what activity you're doing, such as if you're doing something that's visually stimulating, you'll get an increased regional blood flow to the occipital visual cortex. Now, cerebral blood flow is determined by cerebral perfusion pressure and cerebral vascular resistance. The equation right here, CPP equals MAP minus ICP, or CVP, depending on which is higher, ICP or CVP. As far as regulation goes, CO2 is the most potent regulator, and it's directly proportional to blood flow. So as CO2 goes up, cerebral blood flow goes up. As it goes down, cerebral blood flow goes down. And you can see the change about 1 to 2 mLs per 100 grams per minute per 1 millimeter mercury change in PaCO2. In the diagram, you can see some of the other regulators, PaO2 and ICP, which we'll talk about here in a second. The brain is able to auto-regulate its blood flow over varying degrees of mean arterial pressure, so that way you get a consistent blood flow to your brain. Generally, it's consistent over a large range. I have listed here about 65 to 100 millimeters of mercury. Patients that have chronic hypertension can have a right shift, so that means they need higher mean arterial pressures to maintain cerebral blood flow, as you can see in the diagram to the right. PaO2 can have an effect on cerebral blood flow as well. However, has little direct effect as long as the PaO2 is greater than 60. But once you reach the critical point below 60, your body will have an increase in cerebral blood flow. This slide is a review of factors that can both increase and decrease cerebral blood flow. So increasing cerebral blood flow occurs with hypoventilation, whereas hypercarbia occurs. Your CO2 goes up. If your O2 level drops below 60, if you're hyperthermic or warm, and certain medications such as volatile anesthetics, ketamine, and vasodilators. Whereas decreased cerebral blood flow occurs with hyperventilation or hypocarbia, with decreased blood pressure or hypotension, with decreasing temperature, and medications such as our IV anesthetics like propofol, etomidate, and barbiturates. Intracranial pressure, normal being around 5 to 15 millimeters of mercury. ICP is determined by 3 different things. So your parenchyma, which is about 80%, your intracranial blood volume, which is about 12%, and your CSF volume, which is about 8%. So because your head is a closed space, changing the varying degrees of one of these can have an increased effect on your ICP. So signs of increased ICP include headache, vomiting, cognitive changes, papilledema, and cranial nerve palsies. Small increases in one component are usually well compensated, and the body does this by displacing CSF from the cranial to spinal compartment, increasing CSF absorption or decreasing its production, and also decreasing total cerebral blood volume. Now you can see this curve to the right here. Change in volume is on the x-axis and change in pressure is on the y-axis. So for a while, especially over long-term slow changes, the body does a really good job of not having an increase in pressure. However, you hit the critical point where you'll get a rapid rise in ICP with small changes in volume. And sometimes when you have your patients that have signs of increased ICP, they might be approaching this part of the curve. Transmural pressure is defined by mean arterial pressure minus ICP, much like the cerebral perfusion pressure. So an increased transmural pressure can occur with either an increase in mean arterial pressure or a decrease in ICP. So when you're talking about cerebral aneurysms, any sort of increase in transmural pressure can lead to an aneurysm rupture. So you need to also not only worry about increasing blood pressure, but also decreasing ICP. Now another regulator of cerebral blood flow is temperature. You'll have a decreased cerebral metabolic consumption of oxygen and cerebral blood flow with decreasing temperature. So about 8% per degree is what's often quoted. And CO2 reactivity is maintained even for patients that are hypothermic. Cerebral spinal fluid surrounds the brain and spinal cord. There's about 150 mLs of CSF, and it's replaced about 3 to 4 times per day. It's formed in the choroid plexus of the lateral ventricle. It makes its way down to the third ventricle, down through the cerebral aqueduct to the fourth ventricle, eventually being absorbed back into the blood through arachnoid granulations in the sagittal sinus. There are several different types of cerebral edema. The first one is cytotoxic edema. This usually occurs with some sort of brain injury, and it's essentially a cellular injury where the cells are have a failure of their sodium and potassium pump, leading to edema. Vasogenic edema is associated with tumors, and there's an impairment in the blood-brain barrier. It can also be associated with trauma and ICH, but it's much more known to be associated with tumors. And this is generally the type of edema that is treated with steroids. Osmotic cerebral edema is when you have an osmolality disorder, such as hyponatremia or DKA, and you get a fluid shift. And then interstitial edema is where there's inflow of CSF. So this also often occurs when there's impaired CSF circulation, such as in hydrocephalus. The autonomic nervous system, neurotransmitters, for the parasympathetic nervous system, it's pretty straightforward. You have acetylcholine released at the ganglion, acting on a nicotinic receptor, and then you have acetylcholine released at the target site, acting on a muscarinic receptor. The sympathetic nervous system has a little bit more variety to it. The primary way the sympathetic nervous system works is you get acetylcholine released at the nicotinic receptor ganglion, and then at your target site you'll have norepinephrine released to alpha or beta receptors. Now, sweat glands act a little bit differently. you'll have a acetylcholine actually released from their nerve terminal, acting on a muscarinic receptor. The sympathetic nervous system also contains the adrenal gland. Well, you'll get epinephrine and norepinephrine released directly into the bloodstream. It's released after having acetylcholine released by the to its target site receptor, which is a nicotinic receptor. And then, of course, for comparison, you have your neuromuscular transmission. So you'll have a motor nerve that releases acetylcholine onto a nicotinic receptor at the skeletal muscle. All right, next part of the presentation is on neuropharmacology keywords. Here are the keywords. We'll go over some of these, and you can see the bolded, again, are the ones that were asked on last year's ITE. Inhaled anesthetics are direct cerebral vasodilators, and they uncouple the cerebral blood flow and CMRO2. So you get an increased cerebral blood flow and a decreased cerebral metabolic rate of oxygen, and you also get an increased ICP. For nitrous oxide, you likely get an increased cerebral blood flow, increased oxygen usage, and an increased ICP. Some of this can be lessened by co-administration of IV anesthetics, which is the next subset. This includes propofol, etomidate, and barbiturates. So you'll have a decreased cerebral blood flow, decreased CMRO2, and a decreased ICP. Now, ketamine is an exception. You can get an increased cerebral blood flow and ICP, and mixed effect on, or no effect on, oxygen usage. Vasodilators, including nitroglycerin, calcium channel blockers, and hydralazine, can increase cerebral blood flow if the mean arterial pressure is maintained. Some of the diuretics that we use during neurosurgery include Lasix or furosemide. It's a loop diuretic acting to inhibit sodium and chloride reabsorption in the thick ascending limb, associated with metabolic alkalosis and hearing loss. Now, mannitol is an osmotic diuretic, so it decreases ICP by fluid shift. You'll likely get a transient increase in your intravascular volume. This can be concerning in patients with congestive heart failure. And generally, this is not a rapid effect. It does take about 30 minutes to start seeing this effect. And now mannitol can cause hyponatremia, increased serum osmolality, and hypovolemia. So often you have to keep an eye on the urine output and make sure the patient doesn't get too hypovolemic. One of the keywords, magnesium effect at the neuromuscular junction. So magnesium or high magnesium levels can enhance muscle relaxation. They can prolong the duration and reduce onset time of your non-depolarizing muscle relaxants. The next slides are going to cover neuromonitoring keywords, and they're by no means in depth covering these topics, trying to just approach some of the high yield information that will be asked on the test. Somatosensory evoked potentials monitor the posterior cord or your ascending sensory pathways, and when you're describing these evoked potentials, you're going to use your amplitude, which is going to be the height of the wave, and your latency, which will be your time to describe it. So a couple different topics that can be approached on a test for these questions is they'll ask about cord ischemia, what happens to your signal. So you're going to get a decreased amplitude and an increased latency. And generally around a 50% decrease in your amplitude and a 10% increase in your latency is clinically significant. Now, anesthetics can also cause a decrease in your amplitude and increase in the latency. Volatile anesthetics are known to cause more than your IV agents. Some of the exceptions are listed here with etomidate and ketamine, which can actually increase amplitude. And for SSEPs, neuromuscular blockers can actually improve the signal. Now, motor evoked potentials are monitoring the anterior part of the cord, or your descending motor pathways, and these are very sensitive to anesthetics, so generally not recommended to use volatile or especially neuromuscular blocking drugs. Now, there's some factors that can affect SSEPs besides our anesthetics. Some of the physiological factors: hypothermia, hematocrit, hypoxemia, not only from ischemia, but also if the patient has a low PaO2 for some problem with their respiratory system. Hypocarbia can also have an effect. Hypotension to varying degrees if there's ischemia, or decreased blood flow to the area, you could have an effect to the signal. Acidosis can also. So generally, if you have a case where a patient has some sort of issue with the signal, you want to make sure that your patient is at appropriate temperature, their hematocrit is appropriate, they're oxygenating and ventilating at an appropriate level, you're maintaining their blood pressure appropriately, and they don't have a unrecognized acidosis. EEG is used in several different areas. So it can give you information on cortical activity. If you're having ischemia, seizure activity, burst suppression, and your depth of anesthesia. There's 4 general waves that describe it. You have your low frequency, high amplitude delta waves that indicate your deep anesthesia or coma, and also encephalopathy. And then at the other end, you'll have your beta waves, which are high frequency, low amplitude. That's often when your patient is awake, eyes open, and engaged. You'll also have your alpha waves, which are where a patient, or you're awake, but relaxed, eyes are closed, and those are generally a little bit lower hertz. Theta waves, which are in the 4 to 7 hertz range, can be indicative of encephalopathy. On to some of the neuropathology keywords. As you can see, there's quite a few. Definitely some here that I was unable to cover that are very high yield to go over, such as sitting position and venous air embolism. Let's look to see what other ones there are. Some of the neuromuscular junction, post-junctional receptors, extrajunctional receptors, just grouping different categories of disease into what has extrajunctional receptors is good. Some of the anatomy keywords I didn't necessarily go over, but I tried to cover a lot of this stuff. Again, this isn't an in-depth overview of these topics. It's just kind of brushing the surface, hopefully listing some of these high yield points. If there's something that doesn't make sense, please dig into it a little bit more to get some more information. Now, therapy to decrease intracranial pressure. We can group this into a couple different categories. CSF fluid reduction can be achieved via EVD or lumbar drain. You can also, not immediate effects, but Lasix and acetazolamide can do this. Generally, a decreasing ICP by opening up an EVD or lumbar drain is pretty immediate effects. Other ways you can reduce ICP are via cerebral edema reduction, giving mannitol, steroids, decompressive craniectomy, or resection of a tumor also is included on this. Hypertonic saline would also be another point here that I actually don't have listed. As far as cerebral blood flow volume reduction, you can decrease your cerebral blood flow with your anesthetics. You can hyperventilate to decrease your CO2, and then avoiding certain medications or hypertension, which would increase your cerebral blood flow. You also want to make sure that you increase your venous outflow, or at least you don't have any obstruction. So make sure your head is elevated above your heart, avoiding constriction at the neck vessels, and then lowering your PEEP or decreasing PEEP as you can, and avoiding excessive airway pressure. So traumatic brain injury, just some management points. You want to make sure you're maintaining your cerebral perfusion pressure for these patients, generally greater than 70. You want to use isotonic solutions. More importantly, you want to avoid hypotonic solutions. So, using your normal saline, or even using a 3% solution if they did have signs of increased ICP. You also want to avoid using glucose-containing solutions, which can worsen your cerebral edema, as well as there's worse neurological outcomes associated when these patients have serum glucose greater than 180. Also, colloids are usually not recommended in patients with TBI, as they can worsen edema, or they're theorized to worsen cerebral edema if the blood-brain barrier is not intact. And I'm not really going to get into the GCS score as much. That's something that you should go over, but it's used to assess the cortical function, and EVM, 4 points, 5 points, 6 points, graded out of 15. Generally, patients with a score less than 8 or 9 might need to be considered, or might need to be intubated to help protect their airway. Now, these are a little bit lower yield topics, but I think it's just a nice quick review on what a subdural hematoma looks like versus an epidural hematoma, and some of their symptoms. The epidural hematoma is usually has some sort of lucid interval, and it's a middle meningeal artery tear, versus the subdural, which is a bridging vein issue. And then I really like this picture on the right. It kind of shows the different shapes. So if you got a CT scan on your test, you'd be able to quickly point out what type of injury the patient has. And you can see the intraparenchymal hemorrhage as well as subarachnoid hemorrhage on the picture on the right. Now, depending on where a patient has a stroke, they will have varying symptoms. Here are some of the major vessels. The main keyword that's listed here was the MCA stroke, so knowing that contralateral upper limb and face paralysis and sensory loss, and then you can get some aphasia if it's in the dominant hemisphere, and hemi-neglect if it's in the non-dominant hemisphere. I think previously the ACA stroke has been asked, and you get contralateral lower limb paralysis and sensory loss for that one. There's also varying degrees. You have all these different branches. I don't know how high yield they are to go over all of those, but like I said, the MCA stroke was the one that was on our keywords this year. And just briefly touching on subarachnoid hemorrhage. So there's different phases. So generally, the most common source of mortality is the initial, your initial bleed. But then once you survive that, you have different mortality based on, or different etiology of morbidity and mortality based on the timing. So generally, in the first 48 hours, a rebleed will be your common source of morbidity and mortality, whereas later on, 3 to 14 days, you start having a vasospasm as a etiology of your mortality or morbidity there. So some of the ways to prevent the vasospasm, have your nimodipine, and then your general therapy, euvolemia, hypertension, and hyperdynamic therapy, which is in contrast to the Triple H therapy that they used in the past. For subarachnoid hemorrhages, you use transcranial Dopplers to associate or assess blood flow, where having increased blood flow can be a sign that you're having a vasospasm. And there's the Lingard ratio, which is your MCA mean velocity over your same side internal carotid artery mean velocity. So over 3 can be associated with vasospasm, and the higher the ratio, the more severe the vasospasm can be. Pseudotumor Cerebri is a disease associated with increased intracranial pressure with normal CSF and sensorium, and you don't have an intracranial lesion. Generally, these patients have symptoms of headache, and they can have visual disturbances. Treatment for these patients is the removal of CSF, either via lumbar puncture, using acetazolamide to decrease CSF production, and then surgical. You can put a lumbar peritoneal shunt in to help with to help continually drain the CSF. Now, tetanus isn't listed as a keyword that I saw, at least under the neuroanesthesia side of things, but I think it's good to go over this. I have botulism on the next slide, and sometimes they'll ask these questions, and your answer might have something on tetanus, and so it's good to be able to rule those out if you know what they are. So tetanus can be caused by a neurotoxin from Clostridium tetani. Your symptoms will include muscle rigidity and spasm, and the mechanism is what a lot of questions will be asked about for some of these, and you'll get retrograde transport of the toxin on the motor neuron, and then it'll enter the presynaptic terminal of an inhibitory interneurons within the spinal cord, and this is going to prevent the release of GABA. So this is going to inhibit an inhibitory mechanism, and this results in spastic paralysis. Now, in comparison, botulism is caused by botulinum A toxin from Clostridium botulinum, and this is a flaccid paralysis. Patients can also have blurred vision, swallowing difficulty, dry mouth, and shortness of breath. The mechanism for this toxin, it's going to block release of acetylcholine-containing vesicles at the neuromuscular junction. It does this via cleaving a snare protein, which prevents fusion of the vesicle for exocytosis. And it'll also prevent reuptake of acetylcholine at the neuromuscular junction. Multiple sclerosis, which is an inflammation and demyelination of the central nervous system, not peripheral nerve issue. The treatment, just to briefly touch on here, involves steroids and interferon, glatiramer, and immunosuppressives. Each have their benefit and side effects, which I'm not necessarily going to get into here. Some of the management principles for multiple sclerosis include avoiding an increase in temperature, which can cause an exacerbation. Spinals have also been implicated in having an exacerbation, but not necessarily an epidural. And it's generally recommended to avoid succinylcholine as these patients are at risk of hyperkalemia. Postoperatively, these patients can also have risk of respiratory depression or dysfunction. ALS is both the upper and lower motor neuron disease. It leads to skeletal muscle atrophy. These patients often present with muscle weakness and atrophy. They can have an upregulation of acetylcholine receptors, and so they're at high risk of hyperkalemia from SUX because of these extrajunctional receptors. And they are extremely sensitive to the non-depolarizers. And these patients can also be aspirations risks, especially if they have any sort of bulbar involvement. Now, this is a very, very common question on many exams, the difference between myasthenia gravis and myasthenic syndrome or Lambert-Eaton. So I have these summarized as briefly and best as I can. The myasthenia gravis patients are resistant to succinylcholine, but they're sensitive to the non-depolarizers. This is an autoimmune disorder where you have antibodies to the postsynaptic acetylcholine receptor at the neuromuscular junction. These are associated with thymomas, and the pathophys, your muscles will weaken with use or repetitive use. Treatment includes anticholinesterase drugs, steroids, immunomodulators, IVIG, and plasmapheresis. Now, Lambert-Eaton patients are sensitive to SUX and sensitive to the non-depolarizers. This disease is associated with the pathophys involves autoimmune antibodies to the presynaptic voltage-gated calcium channels at the neuromuscular junction. And this is often associated with small cell lung cancer. Now, the muscles for these patients will strengthen or improve with repetitive use. Occasionally this question will be asked on some of these exams as well, which predictors for post-op ventilation in patients with myasthenia gravis. Longer duration, greater than 6 years, large doses of pyridosigmine greater than 750 milligrams per day. Low vital capacity and history of chronic pulmonary disease are probably the main four. And I have some other ones listed on here that I was able to find on UpToDate as being risk factors. Hypokalemic periodic paralysis is a disorder where you get intermittent skeletal muscle weakness, which generally spares respiration. There's both a hypokalemic and hyperkalemic. The hypokalemic one was listed as a keyword on this exam, for this exam. So sometimes, it's important to avoid triggers for this disease. So stress, cold, carbo load, beta agonists can be triggers. And if you carbo load or give glucose, it can increase insulin release, which will decrease your potassium level, leading to muscle weakness. And this is a loss of muscle membrane excitability. It's not a problem at the neuromuscular junction. Now, the neuropathology has a lot of keywords, and like I said, I tried to cover a lot of them, but again, I did skip several. I think it's important to look through those, and if there's a topic that's unclear, I'd recommend looking it up and just giving it a brief read. We're going to move on next to pituitary keywords. Now, quick summary of the pituitary. There's the anterior pituitary, which secretes substances such as growth hormone, luteinizing hormone, FSH, TSH, ACTH, prolactin, and then you have your posterior pituitary, which is going to release ADH and oxytocin. Usually with any sort of pituitary adenoma, it's most likely going to affect the anterior pituitary, so you can get tumors that secrete those hormones. You can get posterior adenoma, but like I said, it's much less common. Some symptoms from compression. As you can see, the pituitary is very close to the optic chiasm, so the pathognomonic, you get bitemporal hemianopsia. Can be a sign that a patient has a pituitary tumor. Now, panhypopituitarism, this is a keyword that was asked last year. It can be suspected based on presenting symptoms of a patient, or if they have a suspicious lesion that is found on CT, such as a suprasellar mass. The symptoms can be progressive. You won't necessarily present with having a hormone deficiency across the board. It can progress, and generally it can be from the gonadotropins to growth hormone to ACTH to TSH. Sheehan syndrome is a specific etiology where it's from postpartum pituitary necrosis, so often associated with high blood loss during delivery. Inability to breastfeed can be an early sign, but these patients will have signs of adrenal insufficiency or hypothyroidism and amenorrhea as time goes on. And your treatment for panhypopituitarism is going to be replace the hormones that are missing, so thyroid hormone and steroids and whatnot. Now, acromegaly is caused by hypersecretion of growth hormone from a functional tumor. So this generally occurs in adult. Gigantism is with hypersecretion of growth hormone in an adolescent. The associations with acromegaly are often potential for difficult airway, since these patients can have enlarged tongue and epiglottis, stiff joints. Other symptoms, they'll also have some glucose intolerance and hypertension, and that can lead to cardiomyopathy. Antidiuretic hormone, or vasopressin, is secreted from the posterior pituitary. And you have osmoreceptors in the hypothalamus that are going to sense an increase in plasma osmolality. This will stimulate release of ADH. You also have stretch receptors in your left atrium that can sense a change and lead to the release of the hormone as well. So what vasopressin will do is it'll help regulate extracellular fluid volume. There's two different receptors. The first is your V1 receptor, which leads to vasoconstriction in your vasculature, although not in your pulmonary circulation. The V2 receptor is where you get your primary response and your antidiuretic response. So this is going to promote water reabsorption by increasing permeability in the collecting duct via aquaporin 2 channel. Diabetes insipidus, associated with pituitary surgery as well as neurological injury. There's two different types. We're mainly going to talk about the central DI, or neurogenic, which leads to decreased secretion of ADH. But there's also a nephrogenic DI, which relates to resistance of ADH, its action on the kidney. Lithium toxicity is commonly associated with this type of DI. Symptoms include polyuria, polydipsia, unconcentrated urine, and hypernatremia. Your treatment's generally going to just be supportive. DDAVP and IV fluids are also indicated. SIADH, or syndrome of inappropriate antidiuretic hormone, has associated conditions such as cancer and lung disease. Certain medications can contribute to it, as well as neurological injury. Diagnosis involves hyponatremia. These patients are usually euvolemic or mildly hypervolemic, which is in comparison to cerebral salt wasting, which we'll cover on the next slide. Treatment for SIADH is fluid restriction. There's also a medication, dimeclocycline, which can inhibit ADH action on the kidney, that can be used in certain patients. Cerebral salt wasting can often be associated with neurological injury and subarachnoid hemorrhage. Very similar to SIADH, you get your hyponatremia, but these patients are going to be hypovolemic, and they're going to have a high urine sodium. Your treatment for these patients is going to be IV fluids and sodium supplementation. This table goes over the different electrolyte abnormalities and volume status, as well as treatment for SIADH, DI, and cerebral salt wasting. Pretty high yield to look over this. I feel like there's commonly questions asked on at least one of these topics for many of these exams. Here are some of the last few keywords that we're going to cover. Risk factors for intraoperative awareness include different case types. They're more common in patients undergoing trauma procedures, emergency procedures, cardiac or OB cases. They're more likely on patients that have a high ASA, likely related to maybe the patient's inability to tolerate higher doses of anesthetic. This includes patients with limited hemodynamic reserve, patients with a history of substance use that might require higher doses of anesthetic, and then also patients with a history of difficult intubation. Now, postoperative visual loss is covered in some different areas for these keywords. I just wanted to briefly mention ischemic optic neuropathy is the number one cause, and it generally causes unilateral, but also, or it can cause unilateral or bilateral blindness. And mainly I wanted to cover some of the risk factors here. So prone procedures, which includes spine procedures, having head down positions, having long duration surgeries with large blood loss, induced hypotension, or patients that have hypotension during procedures are at higher risk, and then giving large volume fluid resuscitation during these procedures can also contribute. Atlantoaxial instability, so flexion or extension of the neck can compress and injure the spinal cord. Some of the associated conditions, achondroplasia, rheumatoid arthritis, Down syndrome, and trauma patients. So autonomic hyperreflexia can occur in patients with spinal cord injury. Usually patients with a T10 or lower lesion won't have this effect, but patients with T10 or higher can have symptoms, although it's more common with lesions that are higher, above T5, T6. So essentially this occurs because there's uninhibited spinal cord reflexes. And as you can see, I think this picture does a really good job of explaining what occurs. So you'll get stimuli below the level of the lesion, either cutaneous or visceral, like the bladder here. The stimulus goes to the spinal cord, and you get a massive sympathetic response where you get widespread vasoconstriction leading to hypertension. Now, the blood vessels higher up above the lesion are going to detect this high blood pressure, and essentially you'll get a vagal response where you'll get bradycardia. Now this response will start to develop anywhere from 1 month to 1 year after a spinal cord injury. One of the key words that was mentioned earlier was a spinal cord injury specifically relating to respiration. And I think essentially with this keyword, it's kind of describing where patients will have issues with respiration. And I think this slide is maybe a little bit more detailed, but as you can see around the cervical area, C5 and higher is where these patients with spinal cord injuries will likely need to have ventilator support. With C5 lesions, sometimes these patients don't necessarily need ventilator support. Now, when you get into the lower cervical regions, patients can breathe independently, although they're still not going to have intact respiration because their intercostal muscles will still not be supporting their inspiration and expiration. And as you move down farther in the spinal cord with these injuries, patients gain more and more function of their intercostal muscles and abdominal muscles, so they'll have greater inspiration and expiration ability. But again, I think some of this question, or what a question could be geared at here is, I think at what level would they have an issue with diaphragm impairment? And again, that's going to be your higher cervical levels there. Thank you for listening. I tried to make this an efficient review of these topics. I utilized several different resources, including Morgan and McHale, Barish, Stoltings, and openanesthesia.org. I also wanted to thank Dr. Schell for some of his previous lectures, which I referenced and included some of that material. Thank you guys. Have a nice day.